Oh, I think we're good. I got us back really quick.
Couple stinkers. Sorry, thank you. Okay, it is 5:30. It's 4:30. I looked at my clock because I'm from Indiana, so I've been looking at my clock for the past 2 days and being extremely stressed and then realizing that it's not the right time. So it's 4:30. Thank you so much for coming today. I know you're probably busy, maybe a little tired, so I'm hoping to keep you all engaged and motivated with this information I have for you today. So my name is Chelsea Mabes, and I did my undergrad at OU, and I recently finished my master's from St. Mary of the Woods. And so what I'm going to be sharing with you today is over 2 years of research that I have immersed into my life and into my practice. So it's a lot of information. I don't want to rush through it, but I have so much that I want to share with you. So I'm going to try my best to sensitively and also in a clarifying manner share what I've learned. I have questions for you. So raise your hand if you have ever worked or currently work with a survivor. And a survivor is someone who has experienced a traumatic event. So raise your hand. Okay. I would say that's like 75% of the group. Okay. So raise your hand if you are a music therapist working in trauma. Sweet. Okay, so 1, 2, 3, 4. We got 6 people. I'm gonna say, what percentage would that be? I'm a musician. I count to 8. Okay. So also, can you let me know? Raise your hand if you've been to any of the trauma presentations at all this GLR conference. Yay! Okay, so a lot of this stuff might be review. But raise your hand if you were familiar with trauma-informed care before this conference. Sweet, sweet. I'd say like 60%, just gauging. Okay. So raise your hand if you work in a facility, organization, or practice where you implement a trauma-informed framework. Cool, cool, thank you. Just some questions to kind of gauge who we are in the audience. Okay, so those are my questions for you. Okay, so what are we going to do today? I'm going to talk about trauma, share some statistics, introduce trauma-informed care if you have not already heard it this weekend. I'm sure that you have. And then talk about my research, my findings, notable findings, and some of the implications for music therapy practice. Again, it's a lot of content, so try to keep up. If you can, take notes and questions, because I would love to answer your questions in the moment, but honestly, I'm not that type of presenter. So if you ask me a question, I will go on a tangent, and then we won't be able to go to the closing ceremony, because I'll be here talking. So write it down. I'll try to make time later for you, okay? Okay, so my research question for my thesis is, what is the understanding of trauma-informed care in the field of music therapy? I didn't learn about trauma-informed care until several years ago. I was working a contract and I received a referral to work with a young girl who had been in 17 different foster placements, and she was referred to music therapy to work through trauma. And I was like, my goodness, wow, what do I do? I don't even understand. So I started to look at the research, and I actually learned that trauma-informed care is a thing. There are even competencies, there are frameworks. So this was brand new to me. And in my research, I developed a hypothesis. I was like, okay, I'm just gonna say less than 30% of us are trauma-informed. So going forward, I'm just gonna talk a little bit more about what that is specifically, because over the past 20 to 30 years, there's been a significant growth of research in the health professional world, not just music therapy, but physical therapy, social work, nursing, regarding the clinical benefits of trauma-informed care and the frameworks and guidelines. However, currently there is little to no research about trauma-informed care specifically for the music therapy profession. And that was interesting to me because a lot of the research I found regarding trauma-informed care show vast and vital, effective benefits to support, and specifically the support that we provide as music therapists. So I wanted to have a closer look and see and explore. There are currently, there aren't any definitive standards for music therapists to follow in order to be trauma-informed. And so I wanted to examine that a little bit further, and if there was an awareness in our field. Music therapy. I love Bruce's definition. Health, experiences, and relationships, and how music therapy has a role in that process. Okay, so the clarification of trauma and trauma-informed care is pretty essential in understanding my research and what I'm going to present to you today. So this is the DSM-5's definition, and it is very critical to understand this explanation because trauma can unfortunately develop into PTSD and acute stress disorder. So I think it is important that we think about, yes, this is what the DSM is telling us for certain clinicians to diagnose, but we don't diagnose. It's not in our scope of practice. However, I have had my own difficulty accepting that this is the only definition of trauma. This is what we call big T, big trauma. And we can all recognize that sexual assault, terrorism, murder, kidnapping, potentially surviving a natural disaster, we can all agree that those are traumatic. You know, those are really difficult circumstances. However, I had this gut feeling that there was just a little bit more to learning about trauma. Just because I wasn't threatened death or serious injury doesn't mean I can't experience something aversive. So this is a definition of trauma by SAMHSA, the Substance Abuse and Mental Health Services Administration. And it recognizes that emotional trauma is also something that individuals experience. Series of events, set of circumstances, emotional harm, however, lasting adverse effects. So with the previous definition of trauma and this definition of trauma is so individualized that, for example, you know, two siblings experience a house fire and one person they're fine. You know, they're able to move on with their lives and still function day to day without feeling triggered. You know, no adverse health effects or emotional or spiritual hindrances. However, the other sibling, they might see a lighter click and then they're gonna go into fight, flight, or freeze potentially. So it depends on the person, and it has to have adverse effects to be considered a traumatic experience. Yeah, this is another visual that I really like when talking about big T and little t. Some of those little t events that we kind of don't think about as being a traumatic event, a car accident, a divorce, the loss of a job or a home. These are all losses. So I had a conversation with a colleague, and we just were throwing ideas around, and something that is traumatic is just a loss of any kind and how it affects you. another big question is trauma-informed care. What is that? And it's relatively easy to get confused with the semantics of, trauma-informed care, trauma-informed competencies. But I think for all of us to be trauma-informed is just implementing trauma-informed care by being trauma-informed, right? Because if you are trauma-informed, then you're innately doing those things. And so I'm going to talk a little bit more about what we can do to be trauma-informed and inherently have trauma-informed care in our clinical practice every day and with everybody that we support. So I have some things up here, and this is also from the American Psychological Association and the Substance Abuse and Mental Health Services Administration. So APA basically defines being trauma-informed as having just the minimal knowledge and skills that working with populations exposed to trauma ought to possess. So populations exposed to trauma, I want us to kind of keep that in the back of our minds. So share with me, if you feel like talking and sharing, share with me a population that you think is exposed to trauma. Yes?
I work with intellectual and developmental disabilities, but a lot of my guys have experienced abuse.
Yes, IDDD. Thank you. Any other populations?
I work at an urban nursing home.
Nursing, yeah. So older adults, potentially?
Yes, predominantly Black.
Mm-hmm. Yes, thank you. Yeah, please.
I work for VA.
Sorry.
VA.
At the VA, yes, veterans, yes. Anyone else? Yeah, Brett.
SUDs and addictions.
Yes, absolutely. Cool.
Children in the foster care system.
Yes, absolutely. Mm-hmm. And I have some experience with that as well. I get you.
I work in forensic mental health.
Absolutely. Disproportionately affected by traumatic events. Yeah.
Kids from a lower economic status and parents are several of the kids that work with parents have been in and out of jail and they've experienced a lot of loss.
Yeah, ACEs. ACEs. So if you've been to some of the other presentations, some of the other presenters have talked about ACEs, adverse childhood experiences. There's a website, if you want to know more, ACEs Too High. And so ACEs Too High, there's actually a quiz that you can take that will give you your ACEs score, because unfortunately, if a person has an ACE score of 4 or more, it's actually shown to take away 20 years off a person's life. And ACEs include, a parent who is incarcerated, witnessing intimate partner violence and domestic violence, did I say divorce, loss of job and home, physical, sexual, and emotional abuse and neglect. Like, all of those things really add up, and it's a health phenomenon. So I'm not going to get too into ACEs, but it's definitely something to be thinking about, especially with childhood development. So I'm loving what I'm hearing. It sounds like everybody's like, yes. I love that IDDD is put into the picture, because, a lot of times we're like, oh, I support this person with Down syndrome, and he's just the cutest thing, and I love him so much. And so we kind of don't get into the mindset that trauma, unfortunately, touches everybody. And I'm going to talk a little bit more about that with some of the statistics, but I don't want to get us too caught in that, because we got a lot to get over today. So yeah, being trauma-informed. The biggest thing that we're going to do today is realizing and recognizing that trauma is there and it's not going away, unfortunately. And then recognizing what these responses might look like. What does a trauma response look like, and how can I recognize that with the people that I support? Yeah, it's a lot. So if you want to know more about trauma-informed care, definitely look at the Substance Abuse and Mental Health Services Administration. There's a lot of resources there that you can really dive into, and for some light reading. But yeah, being trauma-informed is just recognizing that trauma has the potential to be a part of everyone's history. So as a clinician, when we're entering this therapeutic space, we're keeping that in the back of our minds. It's just that question mark, like it could be. So some of the statistics, 76% of adults will be exposed to traumatic events in their lifetime. And actually 30% of these adults have experienced 3 or more In 2018, the CDC reported that 1 in 3 women and 1 in 6 men in the United States have experienced sexual violence in their lifetime, which is startling because that's not actually representative of actual cases. It's just representative of reports, you know, people that came forward. It's not good. And I think collective trauma is also something that we can recognize. Like, for example, 9/11. Not, you know, a lot of us were not in New York City when this occurred, but we watched the news. And then also every year when there's a memorial, these images are on TV and on social media. So with collective trauma, you don't necessarily have to be close to the site to be impacted by it. And also social media just kind of perpetuates things a little bit further. I don't know how many times I've been on Facebook and on the news feed, it's, you know, someone being assaulted by a police officer, or, you know, a child being bullied by someone in school, and that is considered collective trauma. We're exposed to all of this information all of the time, and anything could send us into a trigger or, you know, adverse reaction. Some additional statistics, 80% of women in prison and jails are survivors. People with intellectual and developmental disabilities are actually more likely than the general population to be exposed to a traumatic event. And 50% of people with dementia have experienced some kind of abuse. There's also other statistics that I didn't include, like hate crimes and simple assault. Simple assault. It's like, what's simple about an assault? But that's how it's defined. In 2018, there were 82 school shootings. People who identify as transgender are more likely to experience a traumatic event. Actually, the LGBTQIA population, you know, are overwhelmingly affected by trauma. It's startling. So it's really hard to look at this. So, you know, take care of yourselves. If you need to stand and stretch, please do. I'm not gonna call you out unless you're my friends. Woo! Oh man, it doesn't show my what. I had in the corner, what? Like learning about all of these statistics. And I also have more in my thesis research, like car accidents, house fires, dog bites, hospitalizations. I'll share my email at the end, and if you definitely want to dive into my like 100-page document, I'll share it with you. I will. I don't mind that. So I hope everyone is still with me. I just want to move on and talk a little bit more about the brain. And forgive me if you are already familiar with this information, but I just can't say it enough. The biopsychosocial phenomenon of trauma, and how us as clinicians, we need to have this understanding to better inform our practice. You know, I always ask this, whenever I talk about this, I have a smart alecky question, like, does everybody have a brain? Yes, we all have brains, regardless of levels of functioning or age or anything. We all have brains, so it's important that we understand how the brain works. So I love this. This is so nice. So we've got like the brain stem here, and then the limbic system kind of connects us to the frontal cortex, okay? So the brain stem, that's like the primal survival part of your brain. Like if you were being chased by a bear, you would know, I need to run. It's your instincts. You know, I'm gonna go because I need to keep myself safe. So that's your lower brain right down here. And you aren't using logic or emotional reason when you're in your lower brain. That's fight, flight, and freeze. And so the limbic system and the amygdala connects the brainstem to the frontal cortex, right? So your amygdalas are kind of like almonds, like right here on the side of your head. And that's where emotions and memories are stored. And it's also interesting that I learned that emotions are actually not stored chronologically. They're actually stored in terms of sensory things. You know, like I think I read that smell is actually the strongest sense linked to memory, which is why when I smell chocolate chip cookies, I think about my mom baking when I was like 5 years old. I don't remember anything about being 5 years old, but I smell these cookies and I'm like, oh, I love my mom and I love cookies. I mean, argue with me about that. Cookies. So the limbic system and the amygdala is taking us to the frontal cortex, and that's where emotions are regulated, and problem solving, motor function, impulse control, language development. Like if I want to learn Spanish, or I'm trying to learn how to throw a spiral and failing, but it's in my frontal cortex. So additionally about the brain, cortisol, so the stress hormone, right? Like a little bit of cortisol is healthy, because if I'm stressed about taking an exam, I'm gonna feel a little bit of stress, but that healthy level of cortisol keeps me motivated to study. You know, so that little bit of stress, like I'm stressed, I really want to pass this exam, but I'm going to study, and then that healthy level of cortisol is great for my brain. But if there's too much cortisol, it actually causes death in the hippocampus and a regression back to the brainstem. So if you're too stressed, you're going to go back to your survival instinct and the prefrontal cortex especially, where that's reasoning, processing, and rationalization. It's not activated. If I'm worried about this bear chasing me, I'm not going to be able to go to reason and say, well, I could climb up this tree, or I could jump in the car and run away, or I could hide here. You're not going to be able to access that part of the brain, because that cortisol and that regression is keeping the brain from accessing that. Yeah? Brain talk. I love the brain. I love it. I can't get over how much talk about the brain. It's awesome. It's so meaningful. Yeah, you know, neurotypical individuals live here. They live here where they can rationalize and regulate. And, you know, people, especially children who experience trauma, complex trauma, repetitive trauma, that regression that keeps happening to the fight, flight, or freeze, synapses are being formed. So children, especially developing brains who are experiencing complex trauma, the synapses are forming at the brainstem. So they're constantly like, street smart? That's what I'm talking about, like street smart young children, as opposed to book smart children. Yeah, so the brain is just really getting a workout when these traumatic events occur. And understanding how the neurobiology of trauma kind of informs what we can do about that clinically. I know if you've attended some of the other presentations, you've probably seen this photo. This was a study conducted at Harvard University in 2018, which I think helps further illustrate why I think sometimes we are misunderstanding trauma. We have the healthy brain, and you know, we can see the temporal lobes. That's where emotional regulation is living, and you can see on the abused brain that there's virtually no activity in the temporal lobes. Sorry. So, and also the front of the brain, like I was just talking about, like reasoning, logic, processing. The neurotypical brain is, look at that activation, that's beautiful. It's a gorgeous brain. And then we go to the abused brain, and there's definitely not as much, but we've got more activity in the brainstem. Yeah. So we can kind of see how that brain looks on a scan. So I think the abused brain, it was an orphan. Yeah. Compelling. Yeah, and I think Harvard also found that abused brains actually shrink as well. So brain overload. The brain is overcompensating during a traumatic event. You know, we have, like I mentioned, cortisol. The cortisol is killing the hippocampus with startle responses heightened. the regulation of additional neurotransmitters like serotonin. When serotonin is altered, that is what we could potentially see as aggression. And additionally, cortisol heightened levels increase less pro-social responses and increased aggressive responses. Unfortunately, the brain stuff, as encompassing and whoa as it is, that's not really what interests me the most. What interests me is these are symptoms of symptoms in someone who has experienced a traumatic event, and the responses look different in adults and children. But primarily children, I mean, we're seeing things that I see on almost an everyday basis as a health professional. You know, like dysregulation, perseveration, maybe lack of focus, inability to retain information. Sometimes we see these responses and sometimes I'll assume like, well, this person isn't listening to my directives because they don't like me, or they don't like the intervention that I am presenting, or they have difficulty listening. I'm gonna score that low on my assessment. And, or they are so hyper, they might have ADHD. So if I'm being trauma informed, I'm not going to let myself think that way. I'm going to look at these responses and that question mark is gonna come back in my head. It could be a response to a traumatic event, or potentially the individual is being triggered. It's a lot of stuff. And again, before I get further anymore, again, the reason why I think it's so important to talk about the brain and to understand the brain, you know, because if we're in low brain, there's maybe some agitation or anxiety. There might be some challenges focusing to tasks and staying regulated. So if I know that that's where the person is living in the moment, I'm not going to go to lyric analysis, and I'm not going to go to songwriting, and I'm not going to do my emotion song and then have this person talk about what's going on. I need to be thinking about more low brain interventions like music and relaxation, anything with music and movement, which I'll show you a movement intervention that I've really liked to do, just so I can get us up and I can give something to you that you might enjoy. So understanding the brain and also how it relates to our music therapy practice, because we have different kinds of interventions that we can present, so we need to be recognizing how the brain is functioning in this moment with the person we're supporting, and also how our music therapy interventions require different skill set. It's not really the word I'm looking for, but you with me with, you know, like lyric analysis, and then, you know, if I need to have some arousal reduction type intervention, you know, I can think about what that looks like. Yes. This is another great, I love the iceberg, you know, like the Freudian type of thing. I love so many things. I keep saying that. I could go on and on and on. I'm super passionate about this, and I love everything. So, the iceberg is a really great visual to kind of talk about something like dissociation and repression. Like, for example, the brain is such a powerful thing. So something can happen that is traumatic, and the brain will actually push it far deep underneath here and not bring it to consciousness. So, which is why, for example, a woman who was sexually assaulted when she was a child doesn't remember this event till 20, 30 years after the event. And this is actually quite normal, because repression is actually a safety mechanism. It's keeping you safe. Your brain is trying to protect you. So some memories and events are not going to resurface until that feeling of safety is created. Yeah? So the brain remembers, the brain is changed. The brain. Yeah. So now that we've talked about this, okay. So about 75% of us knowingly work or have worked in survivors. But thinking about the statistics and some of the symptoms or responses that I'm going to assume a lot of us have seen some of that stuff with the people we support, but only 6 people raise their hand as a music therapist that works in trauma. That's the phenomenon that kind of like blows my mind, because trauma is 100% around us. And if we don't identify, I am a music therapist and I do work in trauma, then we're kind of missing the first R in being trauma informed, and that's realizing that trauma is innately with every single population that we support. And I've got some more conclusions later on based on my research that I want to share with you about that. All of us can expect to support people that have been touched by a trauma. Every single one of us. Me learning about trauma. Okay, so I'm going to show you something that I'm a music therapist, so I gotta get some music going. It's kind of music, okay? But so we're gonna do bilateral moving, okay? And I'm gonna use my metronome for this. Cool? Because bilateral moving, especially to a steady beat, is a great way for incorporating movement to activate the entire brain, facilitating entrainment. Okay, cool. So you can stand up if you'd like, or if you feel more comfortable remaining seated, that is okay too. Okay? So I'm going to teach you this bilateral movement exercise. Okay, so just to model, so we're going to flick, and then opposite foot flick, arm flick, and then other foot flick. Okay? So it's kind of silly. I'll count. Okay, you ready? Okay. 8, 7, 6, 5, 4, 3, 2, 1. 8, 7, 6, 5, 4, 3, 2, 1. 8, 7, 6, 5, 4, 3, 2, 1. 8, 7, 6, 7, 6, 5, 4, 3, 2, 1. 7, 6, 5, 4, 3, 2, 1. 6, 6, 6, 6. Here we go. 5, 4, 4, 3, 2, 1. 4, 3, 2, 1. 4, 3, 2, 1. 3, 2, 1. 3, 2, 1. 3, 2, 1. 3, 2, 1. 2, 1, 2, 1, 2, 1, 2, 1, 1, 1, 1, 1. Does your brain feel activated? Bilateral moving. Please.
Just one thing, Dr. Heiderscheid this morning mentioned Bessel van der Kolk, and one of the things he says is that healing happens from the left side to the right side of the brain. And in trauma treatment, where they do like the EMDR therapy, it's alternating bilateral stimulation.
Absolutely. And the fact that I was able to add a metronome to that, as music therapists, yes, that healing that goes on into the brain, but we're also taking into consideration the auditory processing and the inclusion of the steady beat, which, as we all know how important that is and how grounding that can be. And it's also kind of fun when you get to the end. 1, 1, 1, 1. Woo! It's cool. It's cool. But yes, van der Kolk and Bruce Perry. Those are great, just pioneer people that have written books like The Brain That Changes Itself is a really great book. The Body Keeps the Score. That's the best resource to put in your back pocket to learn more about this in self-study. While generalizations can be made about trauma, the experience is so unique to the survivor. I love that you mentioned EMDR. These are, since I'm running a little low on time, I'm going to kind of speed up just a little bit so we can get to the implications. So these are some kind of trauma-informed treatments that I found in the literature. Seeking safety is a really popular one. We really like seeking safety. So, and please, write down my email, and if you want the slides or anything like that, because this is evidence-based. Everything that we're learning about today. I also want to point out that this is not trauma-specific treatment, okay? Because we have being trauma-informed. I am trauma-informed because I'm realizing that what I am seeing could be a response that is stemming from a previous trauma, but I am not administering trauma-specific support. If you want to provide something trauma-specific, you're going to need to get some more training and add a couple more letters to your name to safely and effectively support trauma-specifically. Cool? So we found, oh, I'm sorry.
I was going to say that comment you just made about extra training. I think that's where the difference lies in your report up there, in that we may recognize we work with survivors, but we're not necessarily working in trauma because we don't necessarily have that extra training to do stuff.
That's so funny because that's kind of I agree with you. Annie Heiderscheit and I have spoken on the phone about this a couple times, and Jennifer Secura. Jennifer Secura is a trauma music therapist. I mean, she was responding after the Sandy Hook shootings. That's where she lives, and she's got that extra training and everything. But for me, what I am proposing with my research is it's interesting that we knowingly are working with survivors. We're knowingly recognizing this, but we're still somehow seeing trauma as a separate population. We're not checking that box. And I just think that's interesting that I work with survivors, but I don't work in trauma. So I can work in trauma, but I don't define myself as a trauma music therapist. I'm a music therapist who is trauma informed. I think that's my dream, is for all of us to be trauma informed. And Lindsay Wright has brought up some points to me that I'm just scratching the surface here. This is so encompassing that it's hard for all of us to be 100% trauma informed. But the research that I did find about being trauma informed are just great things. Greater likelihood of continuing treatment. I mean, music therapy support is the most successful when people come every week. Am I right? Like, don't cancel your sessions, because we can't progress if we don't go, right? Better coping skills. Who here works on coping skills with the people they support? Me too. Services are just better for the survivor. They're safe, and I have an ethical obligation to do no harm and to respect the dignity of the people I support, and I think providing the safest environment possible is the way to do that. So I know that being trauma-informed creates a safe environment, and if I want to have the safest environment possible, implementing trauma-informed care into everything I do can only make things better, right? Why limit yourself? Music therapy and trauma. So there are several research articles about specific approaches. Like GIM. Look at all that. And then trauma-informed music therapy approach in hospitals. This is from the Creative Interventions for Traumatized Children book. It's a chapter. It was actually edited by an art therapist, Kathy Maldakai, Malad, I don't know. Google it. But it's just a Getty and Whitehead flow. They adapted a trauma-informed framework that was created by an art therapist and then used it with hospitalized children. And it's kind of the things that I was talking about, like arousal reduction, emotional regulation, body awareness, like I'm aware of my body and space, lots of other things. There's still a lot of work that needs to be done. Yeah, I kind of already mentioned, again, I can't say it enough, the biggest thing is understanding the neurobiology of trauma and what we can do as music therapists. Again, group drumming is going to be great in essentially all parts of the brain, where all parts of the brain meaning if a person is in low brain and high brain, because there's that sensory processing, that moving going on, as opposed to song discussion, like I mentioned earlier. Not to say that music composition and songwriting is not beneficial for a survivor. It just, if we're trauma informed, we're just thinking about how to use these interventions safely. And we can safely do that when we understand the brain. So now I'm gonna dive a little bit into my research. So semi-structured qualitative interviews, 9 participants, social media recruitment. I did something called snowball sampling. So has anyone heard of snowball sampling? Yay! I have not met a person who's known what it is yet, and I'm so excited. So let's say, so this is what I did, right? So I posted my flyer, and I was like, this is the call for participants. Let me know if you're interested. So someone emailed me and said, hey, I'm wanting to do this. And then we did the interview, and then I told the person, if you know of anybody else who might be interested in participating in this interview, have them email me. They were like, oh, well, I can give them your email. And I'm like, nope, researcher bias, snowball sampling, they come to me. One-to-ones, they were recorded. Some of my interviews lasted 15 minutes, and some of them lasted an hour and a half because I met other music therapists that are just as passionate as me. And they tag me and stuff on the Unite page. They're like, oh, Chelsea, you might want to talk about this. I always want to talk about this. Okay, these are my questions. Open-ended, I don't want to lead anybody because I'm exploring. I want to know what my participants thought, what they believed, what they have learned. So these are kind of what these questions look like. Kind of looks like how we would lead with people supported. Tell me more about this. Can you share with me your understanding of this? Yeah. IRB approval, informed consent, photo video release, anonymity. I got IRB approval, and it was a great day. I celebrated. But one does not simply ignore their bias. I'm aware of how passionate I am about this, and I know what I believe. Again, I had a hypothesis. I went in there thinking I think this. That is bias. And so honestly, it was challenging, the transcription process, to authentically document syntax and prosody. It was very challenging for me, but I made sure to send the transcriptions to the participants and made sure that I did not misinterpret their responses. Yeah, it was very important to me to stay in touch with the participants in the study. Okay, I used thematic analysis and Vivo 12, and that was a very terrorizing process because I was not about to pay, so I had 2 weeks on my trial to do this. So think about that. And I did use a documented framework for my thematic analysis. So I wanted to share just a couple of like the demographics. GLR for the win. Boom. Okay, so, and I had people identify where they received their academic training and what region they're in currently practicing. So yeah, GLR, thank you so much. You guys are the best. Yes. Okay. Current setting of practice, primary population in practice. The majority of the participants in the study were in a mental health population, and it kind of varied with the inpatient forensic psychiatric facility and correctional facility, but I just wanted to be pretty particular about that. Medicaid waiver, this is my current home. Yeah. These were my initial codes. I know it's a lot, and I hate to rush through this, but I just want to at least share the overview, and then, of course, if you want the deets, then you'll get my email. But like, these are the most important ones. Survivor's experience, TIC is trauma-informed care, trauma, safety, their story. So these codes led me to my 6 themes. The experience of the survivor, trauma-informed care, competence, safety, with the sub-theme of our safety, the medium of music and the significance, trauma-informed care, and to the music therapy profession. So I have like 10 slides with responses from the participants, and I know it's a lot, but I've highlighted some of the quotes that stood out because the juice is from the people that volunteered to participate in this study. And my research means nothing without their support. So for the experience of the survivor, some notable things that stuck out. Trauma comes in all shapes and sizes. We all have experienced one traumatic event. We've all experienced it, define it for themselves. So that goes back to how trauma is everywhere, 100%. And it's individualized, it's an experience. It's innate to me. I think of the presentation before, she said it's subjective. You know, my subjective, memory of what I experienced might not fit what it actually looked like. She had a really good example. She a 3-year-old was like, the needle was this big, but it was actually this big. But to the 3-year-old, I mean, that thing was probably 3 foot long, right? Because it was scary. Their story, these quotes. Being human is recognizing that we have all experienced trauma in some sort of way. If you don't understand the person, you can't help the person. Trauma-informed care. So the participants shared what they understood about it. So being trauma-informed care is just recognizing how trauma affects an individual, understanding that behavior is a response. We've talked about that. To have as much information as possible about the neurobiology involved in trauma. Another thing that I love, it keeps coming up. The brain, funny thing. Competence, this was fun. I love that people were honest. They're like, I don't think I could give you a definition. It's big and encompassing, but my training was condensed down to like an hour. I honestly don't remember how much we really touched on it. And I think that's interesting. I think it should be included in everyone's coursework. I honestly don't remember how much we touched on it. And I think that's interesting to notice that from the themes and the quotes. Survivor safety. Clinician safety. This is also very important. I didn't really have a lot of time to touch on secondary trauma and vicarious trauma, but it is a part of what we may experience as a clinician. So it's important to keep ourselves safe. And trauma-informed care is safer for the person supported as well as the clinician. That's what the research I've learned. It is our responsibility to take care of ourselves. The medium of music. I love this one. It's a safe medium, not to say music is always safe. And I think that as board certified music therapists, we're not slapping headphones on people and just leaving them in the corner, which I love that we don't do that, because then we're not recognizing that music is not always safe. And if it's not safe for the person, then how can we recognize that? And being board certified music therapists, we're trained to recognize those things so that their survivor is safe. We know that we're awesome. Come on, music therapists. Significance of trauma-informed care. Biological vulnerabilities can be affected by any certain trauma that they have experienced. There's so many things that I wouldn't do without being trauma-informed. It's so important. It's important in all different populations in different settings. You can foster a sense of trust a little bit more. Yes. Significance of trauma-informed care in music therapy. Any music therapist in any setting is going to run across individuals who have experienced trauma. You don't know who's going to come across your caseload, especially as a new professional. It's like, I had an unpaid internship. I gotta work. Like, I need a job. I need to have financial stability. So sometimes you can't control your population supported, right? How can it not be a benefit? It will do nothing but benefit our clinical practice. Sounds like they get it. Do they though? So my hypothesis was that less than 30% of music therapists are trauma informed. And I'd love to, because I usually ask the question, do you agree with that hypothesis? And I'd love to hear more from you, but we've only got 15 more minutes. But we're almost done. So my hypothesis was less than 30%. So you might think I was wrong. You might agree based on what we've gone through today. Do they though? So now is the discussion part. These are my ideas. The discussion portion, drawing from the themes, reflecting back on the literature review that was so extensive and so encompassing, but so meaningful. Most of the participants recognized trauma and how music therapy is a beneficial modality for the survivor, but didn't identify all of the concepts and principles of trauma-informed care, which are the 4 R's: realizing, recognizing, responding, and resisting re-traumatization, and the 6 principles, which we didn't really touch on, like safety, fostering resilience, things like that. Did not primarily discuss the processing of trauma in their work, but like musically, none of the participants really talked about how musically they were processing trauma, but rather music for expression and creativity. And yes, I already touched on this. It's interesting that we've recognized that music has the potential to heal trauma, but did not share experiences in knowingly helping survivors process the trauma through music. And the reason why I come to these conclusions is because, I had to stick to something concrete. So I'm sticking to the substance abuse and mental health services definition of trauma-informed care. That was my framework to kind of make these discussion points, per se. Yeah. Everyone identified working with a survivor at one point. But again, like the discussion point brought up, nobody really identified themselves as working in trauma, but the experience of a traumatic event for survivors as part of the human experience. That was the first slide. Like, everybody has experienced something. It's the survivor's experience. We've all experienced this. And the participants recognize that working with a survivor is highly likely. So, my brain is just being ripped in half that I'm sensing a hole there. But it's not just my research. Kind of what we touched on earlier about this question, and I invite you to think about that and how you feel about that. Whether or not you identify, am I a music therapist that works in trauma? Is that appropriate? Does that really, and feel free to talk to me about that. Reach out on Facebook, because this is not something that's gonna stop. It's gonna keep going forward. You know, am I a music therapist that works in trauma as opposed to a trauma music therapist, like trauma-focused music therapy work that you kind of live in? But, you know, I am still, my opinion, my bias, is I think that we all should identify that we work in trauma. And the workforce statistics, less than 3% of music therapists identified working with trauma and children who have undergone trauma. Like, you know, when you're looking at the survey, it's got like all of those statistics, like boom, 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 this is where everybody works. And then this was on the very bottom, like very, very bottom, the lowest percentage. And there was also 20% of music therapists identified working with abused, sexually abused, and PTSD, but which we know that is a very small portion of what a trauma is considered to be, right? Like thinking back to the trauma definitions. So that's the biggest thing I'm taking away from my research. It's like, why aren't we checking that box? Are we being trauma informed if we're not checking that box, if we're not identifying that we work in trauma? And, you know, trauma being a population separate than what we do. You know, I work with intellectual and developmental disabilities. I don't work in trauma. So I want to check both boxes. That's what I'm proposing. Just to recognize that trauma is everywhere and not just, you know, this other population in the corner that I'm not going to work with ever at all time, which that's not what the research tells us. It doesn't match. So if we don't think we're working in trauma, it's unlikely that we're really having this awareness. And it's a recognizing is a key element to being trauma informed and ultimately the safe environment for the survivor that can lead to healing. Because if I don't feel safe, I'm stuck in fight, flight, or freeze. Most of the participants noticed the importance of establishing a rapport. We all believe that. Individualized support. Hearing the person's voice, their story, their experiences. These are factors that contribute to safety, but listening to a person and being open does not necessarily create a trauma-informed environment. You know, it's just one element, right? Because there's a lot of elements. Safety for the music therapist, yeah, that's definitely, you know, again, secondary trauma, vicarious trauma. Sorry, there's a lot of text on these slides, but we're almost done. Only 2 of my participants talked about how being trauma informed was safer for them, which was interesting because, you know, with Bruce's definition, we're talking about healing and relationship. This isn't a one-way street, buddy. Like, it's the music, it's me, and it's you. So I also have to take care of myself. And so I can be safe. So the participants that learned about trauma-informed care in their undergrad didn't really remember it. All of the participants learned about trauma-informed care from self-study or workshops and training provided by their places of employment. And I remember that quote, the biggest quote that stuck is, I think it should be included in everybody's coursework. You know, so music therapists, they shared with me what they think they needed, what they thought that they needed from their undergraduate experience to be better clinicians. So, you know, blanket statement, if it's included in our coursework at the undergraduate level, then we're gonna be more prepared to support anybody and everybody that's gonna come onto our caseloads. I didn't have any idea how to work with trauma until I was 3 years into the profession and I got a referral for it. I was completely in the dark. There's just still a lot more awareness, and this is the first conference I've been to where I'm like, wow, there's actually more than one presentation about trauma. This is awesome. Yeah, a greater presence of trauma-informed care at the undergraduate level in order to prepare them for careers as music therapists where they may work with any age or population. But I've got some limitations. It was a small scale study. It was exploratory. limited to the US. I didn't have any participants from 3 other regions, and I did not have I was not able to transcribe an interview with someone of more than 8 years of experience. I actually interviewed a participant with over 30 years of experience, and my transcription, it didn't record. So I had to throw it out, and it was such a shame, and I was so heartbroken, but that's why that happened. So my tech skills are just ugh. Also, another limitation I think is like the social media recruitment. You know, my flyer was, you know, clearly like trauma-informed care, and I feel like the people that decided that they wanted to participate had kind of already heard about it, as opposed to somebody's like, I've never heard of trauma-informed care, so I'm not really interested in the study. So, you know, the work is obviously not representative of our field as a whole. It's just a really small snapshot from the people that participated, you know. I want to ask, I would love to ask everybody, but I can't. Okay, you made it through. So raise your hand if you have ever worked or currently work with a survivor. Everyone, we all do. So just by raising your hand, you are more trauma informed. Questions? Yes.
So this goes back to what you had said about when we're looking at a child or working with a client who is exhibiting behavior, and we think, oh, they're just not a good listener, or they're just not paying attention, but really there's probably a different situation happening.
Could be, yeah.
Right.
Mm-hmm.
So, so how do we change our thinking from oh, they're just a bad listener to maybe there's something else going on? Is it for us to practice trauma-informed care at all times?
Yes.
Is that okay?
Yeah, I mean that's my thought, you know, because every time I go into a session, I'm thinking, I'm also thinking about, like, you know, for this child, you know, I'm also thinking about, is it something in the environment that could be triggering this type of response? You know, like for example, this young girl that I actually received the referral for that was 6 years old and in all these different foster homes. And I've told this story before to some of my friends, but she was in her foster placement, and the foster family, they were so nice. They wanted to give her her own space. So the basement was completely hers. She had her own bathroom, playroom, bedroom, and everything. And her music therapy support was also downstairs. And I was seeing exactly the things that you just mentioned, you know, difficulty regulating, difficulty maintaining focus, and just, it was challenging to do a session. And I genuinely thought that she hated me. But then we got the case history back, and we learned that she was actually sexually assaulted by her brothers in the basement. So it was the triggering environment. So, you know, if I was trauma informed, which I wasn't when I first started this work, I could have thought about, is this an environment that's safe? Because she wasn't feeling safe, was she? You know, to be responding in that way, we've learned that. So, of course, I didn't think about that. I didn't have my trauma-informed lens when I started working with her, because it was just like week after week after week, I'm not getting anywhere. Do I need to terminate? But that wasn't it at all. As soon as we got her out the basement and moved her upstairs, we really started to get somewhere. So does that kind of give some insight into what I'm thinking?
It was, oh, for sure. I completely got what you were thinking. I was just trying to think, like, from outside, you know, because I'm practicing with other music therapists, or even working alongside other professionals.
Right.
When I receive a referral, I'm out in the community, so I work in many different places, but I'll get a referral at a school, and the first thing that I'll get from the SLP will be, oh, well, that's a difficult child, they don't listen. And after I got some trauma-informed care, I would then say, well, is that actually what's going on, or is there something else going on? And then we would find out a lot of the time that they had just been moved into a different foster family,
right?
Or there was a change, not just a change in medication, but like a change in who was distributing medication,
We're looking at
Like,
behavior
there was
as
so much, right, there was so much going on, so that's,
yeah,
I was just thinking, like, maybe we should be practicing trauma-informed care all the time.
all the time, baby,
Versus
all day,
just
every day.
only when we have a referral for trauma, or for trauma groups, or, you know what I mean?
Yeah, you know, and I think you bring up a good point. And another thing that I want to invite us to do is to have some sensitivity about this knowledge going forward, because it's so easy to walk away this weekend and then just see trauma all over your caseloads. But we're not diagnosing trauma. And we also need to have that sensitivity where, I love how you said, maybe something else is going on. I think that's the best way to put it. So with this trauma-informed lens, I'm gonna go into every single session with that question mark in the back of my head, like, it could be, it might. So I'm going to structure my therapeutic space or the way that I'm talking to people in a way that's trauma-informed. Like another example, I love giving examples. I do not ask my students that I support how their holidays went. I don't do it. I don't ask them. Because, first of all, the month of January was absolutely miserable for some of my students because they didn't have their lunches every day. They couldn't see their teachers every day. They were potentially in a home environment that was stressful. And I could see those responses as soon as we started school back up in January. So having that trauma-informed lens, it changed. And unfortunately, I knew that going in because of the prevalence of trauma, especially with, you know, students that ED, emotional disturbances. I hate saying ED. I think it's unfair because I think ED are trauma responses, and we're just slapping a diagnosis on it, like, oh, well, you're emotionally disturbed. Well, anyways, that's another tangent. Maybe that'll be my next research project. But yeah, so unfortunately, I innately went back to schools in January knowing that I was going to have to be very careful to have a safe environment for these students so that they could be successful. And there's a documentary called Paper Tigers. And Paper Tigers is about a school in Washington that actually developed a trauma-informed framework in their high school. And their graduation rates like spiked, you know, visits to the nurse decreased. Like, these students were healthier, they were happier because of a trauma-informed lens. And one of the biggest things that we can do to foster resiliency and even have a role in negating some of the negative effects of trauma is to have a positive, steady adult in a child's life, aka music therapist every week. You know, we have the potential to fill that role. Hi.
So once you start considering, is this aberrant behavior or is this a trauma response? How do you kind of make that decision as to which direction to follow in your clinical work with that person?
Well, the direction that I choose to always create is the feeling of safety and openness, always. And for me, it really started to move into my clinical work whenever I started learning about this. For example, if I have a person that I support that is feeling a very strong emotion, and I'm seeing crying, potential screaming, I want them to feel safe, so I'm not going to have any objects where they could grab and hurt themselves or someone else. I'm also going to make sure that I am not re-traumatizing them anymore. Maybe the song was, so to answer your question, there are a lot of thoughts in my head about what direction I'm gonna take my session. However, the biggest thing is to just be open and listen and never push. I've had people say, Miss Chelsea, I don't want to talk about it today. And some people might be like, oh, well, I'm your music therapist. I'm here to help you. Can you tell me more? I want to help you. Maybe you want to try this. Maybe you want to try this. he just said he didn't want to talk about it. And as much as we want to help and be there, we need to be open and understanding and just sometimes accept and move on. So I wish there was a black and white answer to that question, because there's so many. I mean, we've all been in clinical settings where there's a million thoughts going through your head, and it's just like, well, I could do this, I could do this. Also, sometimes you don't have to say anything. You know, maybe that's the moment where you need to bring out a drum and ask, you know, see if the person is comfortable drumming what they're thinking or what they're feeling. You don't have to talk to me about it, because I'm a music therapist and I can see, and I can be here and I can support you and have that safe space for you. Yes.
How would you suggest that this be applied with mental regression, with like our folks with dementia? Because we see a lot of elder abuse or neglect, but it may be hard even communicating with them.
Yeah, absolutely. That's a really great question, and I would love to have more answers, but I don't think I have an answer for that specifically. If that's okay.
Yeah.
You know, because I it's one of those things where it's like, I want to know everything about this, but there's some things that I don't really know. You said you said dementia, right?
Yeah, like with our older folks, and this may
In the
not
home environment specifically, or
in the home environment or in a facility, whether that be like elder neglect or elder abuse, or simply the trauma relating to loss of independence, like loss of a home and loss of abilities.
You know, I'm also thinking potentially about how, you know, we can be thinking about, because you mentioned communication. We can think more about their responses once more, but also taking into consideration that this person, you know, has dementia, or, you know, we're taking all things into consideration. So, you know, the person might not be communicating with you because of their dementia, or they might not be able to communicate with you because they're triggered. So it could be, I would look at their responses, I would look at their body language, I would look at how they're playing their instruments and things like that. Now, I think that's my first step to answer the question, and I'm gonna learn more. I want to.
I work in that setting, so
Cool.
that's so.
You and Carrie need to hook up and talk.
Yeah, like I have a feelings drum, so I keep a small little purple djembe with me at all times. I use this at school too, but so if someone says I don't want to talk about it, I will often say, well, would you like to play it instead?
Yeah.
And so I get really great responses that way.
Yeah.
And one of the things that I'll do on the memory unit is it's not so much verbal processing as much as it is like improvisational play, and I will imitate them versus, you know, and so we'll have like a musical discussion with the instruments. They don't always remember my name, but they know that when I'm coming in, that I'm a person that is safe, that I'm a person that's there to support them. One of the other challenges that I face is that because I'm at a nursing home that's predominantly black, is a lot of the trauma that my residents have faced is racial discrimination. And so because I am
hate
white,
crimes.
Right, and so because I am white, sometimes I become the trigger when they first come in. And so that's just real talk and real situation. So sometimes
That must be difficult.
yeah, so sometimes I have to bring a nurse in with me because their staff is also predominantly black.
Yeah.
So sometimes I bring a nurse in that they trust, and we try to have the nurse interact with me and have them interact so that it becomes they learn that I'm a safe person, even though that I'm white, and their experience or their trauma was because of whiteness.
And it's great that you're recognizing the cultural aspect of being trauma informed, because that is one of the 6 principles, you know. And I love that you're sharing the feelings drum, because we're so lucky to have a modality where we don't have to necessarily speak. We can have that nonverbal aspect of creating a safe and trusting environment, and music is relational, and so our music is forming that relationship. Well, I'm ready to sign anybody's stuff, and I want to say thank you. Thanks for staying. A little late. I guess I'll just thank you for your insightful responses today. Oh, I'm so excited. I love it. I love it. I'm looking forward to doing something like that. Because I'm finally done with my thesis. Yes.
Yeah, well, I'd love to incorporate more like
Thank you for your insight. Yes. Yeah.